Thank you, Dr. Kudlow. Thanks for this opportunity. Dysphotopsia is when your patient has very good vision but he's still unsatisfied because he is seeing more than 6:6. What is he seeing? I'm not talking about the glare that the halos that you expect with multifocals, because this you already know about and you would have counseled the patient that initial period these halos will be there. There are a multitude of other problems like glare, starburst, flare, and all, which can be seen by the patient, and this will make the patient unhappy. So you have positive as well as negative dysphotopsia. Positive come in the form of bright light, in the form of arcs or streaks. Negative is a temporal dark shadow that most of our patients always complain about. There are no objective tests for this dysphotopsia. It's always based on the patient complaint. And remember, you should always distinguish this dysphotopsia from vitreous traction, the retinal vitreous traction, as well as a linear streak by if there is a linear streak in the posterior capsule which is causing the Maddox rod effect. So distinguish this from a positive dysphotopsia. So positive dysphotopsias, as I mentioned, can be an arc, a central flash, or a flare. Arc is when the patient perceives the edge of an IOL in a scotopic pupil. It generally resolves over time as the peripheral capsule opacifies. Flare is caused by a small cylinder or a coma remaining. Correcting this small cylinder with his spectacles will resolve this. And also putting pilocarpine, especially in the afternoon, so that evening his pupil is smaller in the initial days, will help in reducing these symptoms. Central flash, sometimes the patients complain about. This is because of a total internal reflection at the edge of the IOL. Again, the IOL manufacturers have made changes to the square edge lenses to reduce this. So here what's happening is that light is coming, hitting the peripheral edge, which is getting reflected inside, causing this central flash. Starbursts are when a backscatter from the surface of the lens cause multiple small spots in their vision. So these positive dysphotopsia are more common in square edge IOLs. Earlier there were some IOLs with an oval optic. Again, these had more positive dysphotopsia, and also IOLs with a very high refractive index like an Alcon IQ. So changes made by the manufacturers are from the square edge, rounding of the anterior edge. This makes sure that there is no much internal reflection, total internal reflection happening there. The light just gets scattered. As long as it's not totally internally reflected, this edge glare won't be there. And also decrease in the thickness at the periphery compared to this. Here, if you see, it's a lenticular design. In the periphery, the thickness, when it's decreased, these changes have been incorporated by most manufacturers over the past 10 years or so, and therefore these positive dysphotopsia are rarely seen in patients now. Correcting any refractive error and ocular surface disease, as Dr. Rohit mentioned, are very important. These can also give rise to these symptoms. If there is any posterior capsular opacification, even in the early stage, if this can cause some blurring, and all these symptoms can get magnified. In the initial days, pharmacological miosis, if you prescribe pilocarpine in the afternoon hours, so that in the evening when they get out, the pupil is smaller, limited to 3 millimeter or so. Therefore, these positive dysphotopsia won't be there. In case if it's an IOL problem itself, then the IOL has to be exchanged. Coming to the more difficult to solve negative dysphotopsia. Here the patient complains of a dark temporal shadow in the periphery. It's an arc-like image. Initially around 1/3 of the patients complain about this. Later, within a year's time, this naturally settles down. It is seen most commonly on the temporal side, and more than 75% of the patients who complain about this negative shadow, it's always in the temporal. This is probably because the nasal retina extends more anterior, as well as light coming from the temporal side is not blocked off like in the nasal side. This is always associated with a IOL which is totally in the bag. It is not seen if the IOL is in the sulcus or partially if one haptic is outside. It can occur with any IOL and incision in any location. Basically, it's an anatomically perfect surgery. If it's anatomically imperfect, the patients don't get negative dysphotopsia. So negative dysphotopsia means that you have done a very good job, but the patient will complain about this. It's more common in higher powered IOLs. This is how a patient would typically describe it. In this patient, if the left eye has been operated, on the temporal aspect on the left side, the dark shadow is there in his vision. There are two schools of thought for this. Holliday said it's the edge penumbra because there is some varying refraction of rays, some area which will cause the negative dysphotopsia, dark shadow there. This was countered saying that it still occurs with the round edge where the scatter is a little more and therefore there is no dark area. The other theory is that it's because of the position of the IOL, the effective lens position. When it is more posterior, there is going to be a gap between the pupillary margin as well as the IOL, wherein rays of light can pass unrefracted. Through the IOL, they would pass refracted. The rays in the more periphery would go in directly to the periphery of the retina. So in between, there will be an area which is not receiving any light, therefore causing this temporal dark shadow. So here you have unrefracted light directly going in. The ones which are hitting the periphery of the IOL are getting refracted and going there. In between this area would be the dark shadow. Surgical management, if necessary, would involve putting a piggyback IOL in the sulcus so that this problem of unrefracted rays is not there. You're going to be blocking off some rays in between them, or doing a reverse optic capture by getting the optic of the IOL into the sulcus, or repositioning the entire IOL in the sulcus. There were certain IOLs which were described known as a dysphotopsia IOL, wherein you're supposed to tuck the anterior capsule into the ridge of the IOL. However, most of the time, just masterly inactivity does the best job. In the initial slide, I told you at the end of 1 year, it's from 30%, it becomes only 3%. We all don't see our physiological blind spot. We don't perceive the retinal blood vessels. Our cortex generally learns to suppress this over time. So masterly inactivity is the key in most cases. Only around 2 to 3% would still complain of them. This we have to handle with care. Explain to the patient that it might go off later. Basically, doing nothing solves this problem. You've already done an anatomically perfect surgery, therefore it would settle down. Thank you.
Thank you, Dr. Vikram. I think most of the complaint, I think most of us do agree here, especially for negative dysphotopsia with the arc around.
Yes.
They keep telling there is arc around, what to do. So I think you have to keep assuring them. And any other drops will really help?
Placebo effect. We would still give them a thicker lubricant or something. The placebo effect, when they see it going off, they'll think it's because of the drop. They'll continue the drop for 3 months. It will go off, and he's happy, you're happy.
With some antioxidant also.
Some placebo, yes.
Yeah. Thank you so much, Dr.